Yeah, so actually, since we were kind of going that direction, uh, so obviously PRI influences what you do to at least some extent. Um, uh, so I guess the trend I've seen is that a lot of people who were using it, it was like everything, it was like everything was PRI, and then talking resilience, some of the people at Rehab to perform, some of the people you see are not necessarily moving away from it, but it's not so heavily influenced where everybody just goes on their back in 90-90 and fixes every problem in the
Yeah.
world. So I would guess my question would be like, how much is PRI influencing what you're doing now? How are you doing it? What are some like mainstays and main focuses that are PRI influence that you're like kind of always using? And what are some that you're just like, fuck that?
Yeah. Um, I would say I'm just more or less trying to integrate some of the concepts as best I can into like standard fitness exercises.
Okay.
Just because number one, a lot of the PRI exercises, um, some of them this isn't true, but other ones it's kind of like there's so much coordination involved with performing the task of it that the individuals doesn't necessarily feel like they're working very hard. So if you have someone who feels like they need to have a hard exercise to do them any good, then you're going to lose their buy-in. So if you're able to incorporate it with a fitness exercise that does challenge them, now you have kept them bought in. Secondary to that, there's a lot of people who just, I mean, from working in general population, like there's people who just don't have the coordination to do some of those exercises. So that kind of limits your scope of how much like PRI you would be doing. And then I've kind of gotten away from the asymmetry side of things a little bit, where it's kind of like you always do something on one side and always do something on another side, just because I feel like that feeds into more of like a scarcity mindset for the individual, where they're a little bit more fearful of doing things. Whereas, I mean, the ultimate goal for somebody is to be alternating and reciprocal. So they should be
Mhm.
able to do something on both sides. And most PRI stuff, and really some of the stuff that you're doing in the gym that's fairly low level, you know, they should be resilient enough to be able to do that on both sides and not go off into a tizzy of symptoms getting flared up. So, yeah, the big thing that I just kind of preach was maybe there is something where I feel an asymmetry is contributing to it, but in that case, then we'll do two on the left and one on the right, or even if I feel like it's the right side asymmetry, then we might do two on the right and one on
Mhm.
the left. But then also the more you combine it with fitness, now you're also able to work strength, capacity, general physical preparedness, and hit all those qualities at the same time. Whereas
Yeah.
none of the PRI exercises do that. And
Right.
that's their biggest pitfall, I feel, is it just lack of contribution of strength, endurance from the standpoint of muscular endurance,
Hmm.
and just general physical preparedness.
Right. Yeah. So so this big article that I have here, they kind of have a lot of these, I guess, common PRI tests. So I'm trying to find them. Oh, come on. So like the first one is kind of, I guess, what we would learn as the Ober's test.
Yep.
Yeah, I mean, they call it, I guess PRI calls it the adduction drop test.
Yep.
So obviously, like in school, we learned that this is seeing the tightness of the IT band, which um, is what school says. Now, I guess my question, my thought process, what the better way to look at it is if someone can extend and then like extend through the hip, not the low back, and then can they adduct? They take it in this little paragraph here, they take it a step further, and that gives you an idea of where the femoral head is in the acetabulum, which I guess makes sense because if it could extend and then adduct, then it's, I guess, centered, is right. It's not anterior, posterior, or any malposition like that. Um, are I? It's such a common test. Do you use it frequently? Do you like what value do you place on it? Like when are you kind of saying, oh, we got to test these two qualities or combination of.
Yeah, I use it quite a bit. I probably don't use it as much as I did like 1 or 2 years ago, but I still
Hmm.
use it all the time. I prefer the Ober's test over the Thomas test, just because I think it gives you more information. So it's a more useful test to do, and it's usually pretty comfortable for the patient to do, whereas sometimes the Thomas test is just kind of like an awkward test for people to get into, just with their legs draping over the edge of the table and laying down. But as far as, so like what school teaches you is, 100% false there with the
Yeah,
IT band. So
yeah,
I don't know if you've ever seen the paper. It's investigation of the Ober's tests. There might be some other words in there, but um, anatomical investigation of the Ober's test. I believe that's what it is. So what they did is they cut the IT band and cadavers, and like there was no change in the Ober's test. So what they're thinking that it has to do is either it's capsule related, it could be glute med related, and then it could also be position related too. So if nothing more, it narrows it down to those three things. What I like the Obers, well, so if I'm looking at position, I'll actually consider it more of like a straight hip flexion test more now.
just a
So like a knee,
supine hip flexion.
supine, knee to chest, checking hip flexion. Yeah. And just getting a sense of what somebody feels. So if they're feeling a lot of like pain, pressure in the front side of the hip, or if they can't get their hip, past 90 degrees, knee not being able to flex past 90 degrees is a bigger problem than someone just feeling a little bit of pressure at 120 degrees. But that to me gives a little bit better indication of like the hip socket
Position. Hmm.
orientation. And then, I mean, it's kind of like you're doing the, what is the test? Craig's test. Um, Craig's test is the one for anteversion, retroversion, right?
I think so. I was horrible at memorizing the name, like the last
Yeah.
names of.
I've never used that test, quite honestly. I know it's used by some people and in some research, but I just like it more from a standpoint of like, so in that test, whether I got the name right or not, that test you're laying prone and you're trying to feel for like the greater trochanter. So
Yeah, yep.
you're
I didn't.
moving palpation out of it. Just by having them flex their knee straight up. And the biggest thing is most people, when they check hip flexion, like they'll let the tibia do whatever they want to do. So like the foot sometimes can be bias the hip into external rotation simply because they didn't keep the tibia parallel.
Straight. Hmm.
So when you do the hip flexion, you want to make sure that the hip stays in hip flexion the whole entire time, because if you
Right.
start allowing the knee to fall out or the foot to move inward, now you're just biasing them into like the scapular plane for the hip.
Hmm.
So I mean, that tells you a lot, because it tells you, okay, the hip is probably oriented and the socket is probably oriented in that fashion to where it wants to kind of turn out like that. So um, it'd be more retroverted at that point in time. But so that's what I use from more of an orientation standpoint, is just,
Yeah.
how much force do I have to use to keep them parallel,
Mm.
and not bias themselves into internal or external rotation. And then how far of hip flexion do they get, and what's the feeling of that hip flexion.
Hmm.
So I use that to give me a little bit better judgment of position. And then the Ober's test, it tells you a bunch of different things, because when you initially set somebody up and you get them kind of in that fetal position laying on their side,
Hmm.
and you pick the leg up and you move it around, one of the first things I'm checking, I'm not even worried about hip extension of the top leg. I'm just seeing how well can they keep their hips stacked on top of each other.
Okay.
Because many times you'll just notice the top hip just roll backwards. And so what that tells you is they can't internally rotate their innominate on their femur very well on the downside leg, because they're rolling backwards. I don't know if
Okay.
maybe I can draw that, and that might make a little bit more sense if they're not visual of it.
So the
Yeah, considering it from the bottom angle. So you can see that, right?
Yep.
My stylus is not working. This is going to make it a lot harder to do it with a mouse. Okay, so one leg's there. This is the bottom leg, flex to 90. And then you got the top leg kind of back like this.
Mm-hmm.
So when you're in this position here, whether you're looking at hip extension or not, but the further you take them into hip extension here, the more you'll notice that. So if this is the greater trochanter right here,
Mm-hmm.
the more you'll notice that rolling back towards you when you're doing the test.
Right.
So you have to use your hand as a counter
Right.
to make sure it doesn't do that. But getting an indication of, if I have to put a lot of force to keep that hip there, there's some resistance in the downside hip to be able to orient itself into internal rotation or a stance leg position. Does that make sense?
Yeah, I understand the movement, what's happening at the top hip. Why is that indicative of the bottom hip, I guess is my question, or the bottom side,
Yeah, so
is it almost like the ability to, I'll say, dissociate the kind of top hemipelvis from the bottom hemipelvis, like have them in different orientations?
correct. Your depends on which phase of the gait. So like if you look at this like a gait cycle, like this person would be in a stride stance
Right.
position. So if we call the downside leg its stance leg,
Mm-hmm.
you would expect, if we're in mid stance anyways, you would
Yeah.
expect that the pelvis is rotated over top of that fixed femur there, right? So that the
Yep.
innominate is positioned in internal rotation.
Yep.
So if you struggle rolling them into that position, then they're going to struggle to achieve mid stance in the gait cycle from a pelvic orientation standpoint.
That makes sense.
The other thing you'll see is maybe you push the hip forward, but because this is not in closed chain, you're in open chain, you'll see the foot rise up off the table.
Mm-hmm.
And so they're biasing themselves into external rotation by doing that. So then you know that they can't internally put themselves into a mid stance internal rotation position very well.
Mm-hmm.
So that's something that I'm looking at as I do that. That's usually actually the first thing that I look at. And then I'm looking at, okay, how well is the knee, hip, and shoulder all in a nice straight line? Or as I extend the knee, does that create like an arch? Does
Like
that
that
create
low
an
back.
arch at their low back? Yeah. Or sometimes it doesn't even look like there's an arch there. But they say that, I feel it in my back.
Mm-hmm.
And that's another just indication to me that, okay, they're probably somewhat extension bias
Right.
with that. So those are the bigger things that I kind of look at. And then, I mean, if they can't do either or of those, there's no sense of really looking at adduction
Yeah.
because they can't get into position because once you do adduction here at the top leg, now you're putting them into mid stance at the top leg.
Mm-hmm.
So that there's no sense of checking the top leg if they can't line everything else up into a position that's relatively in a straight line.
Right. Okay. That makes sense. The linking it to the gait, actually, like someone walking makes
Yeah.
kind of clears it up a little bit more. Yeah. Okay. That definitely makes sense. So I guess a similar question. So like they kind of use a supine, just I guess passive range motion shoulder internal rotation test to indicate I guess like a rib cage position, like flared or not flared. So is that something? What was I going to say? Yeah, so like they would say on the right side, typically you're going to find a limited internal rotation. On the left, it is usually fine, like usually a negative test. That's what this article is
Yeah.
saying.
PRI would
Uh,
say that the right shoulder internal rotation would be limited, and that would be
yep.
normal pattern. Yeah.
Right. All right. Yeah, that would exactly. Um, is that something you were thinking about, or are you just checking internal rotation if you need to check that? Just see what the difference is. Are you thinking this
Yeah,
way, or are you kind of
you'll
just?
definitely notice it a lot. I mean, what they talk about the pattern, like the more you start looking for it, the more you see it in everything.
Hmm.
Again, so when you go to a PRI course, they wow you with being able to change the range of motion drastically. Not in every circumstances, but they're also very good at being a clinician and knowing pattern recognition as far as who's going to make a quick change and who isn't. So that's why they never pick somebody who isn't going to make a quick change. So they always look successful. Um,
It's like a medium,
Granted,
right?
to a certain extent, they probably can do it in a lot more people than, the majority of people who are just, gradually exposed to their science. Um, but it does work for a lot of people to be able to change that range of motion, but range of motion isn't always, pain is so multifactorial. Range of motion isn't the only factor that can influence pain. So,
Hmm.
it might change the range of motion. Most of the time when they test it on somebody, that person isn't really painful either to begin with. So,
Right.
does it really matter that they changed it? I don't know. For somebody, it could definitely, but for other people, it might not be a range of motion thing that is the biggest factor contributing to their pain. So, does it matter? If you think it matters, yeah. So
Right.
I look at total shoulder range of motion. That's where I make my judgment. Like if they don't have total shoulder range of motion of 180 degrees or their whereabouts,
Hmm.
then they have a shoulder range of motion issue,
Hmm.
and you probably need to start improving shoulder range of motion. If they have 180 total degrees of shoulder range of motion and they are limited in IR, then it's usually a positional thing. Um, so then it's a matter of if you feel position needs to be addressed. So in that instance, you would ask yourself, how much do I feel is biomechanics playing a role in everything and load distribution. So you can have an overload scenario from a simple programming standpoint,
Hmm.
from somebody working out and not necessarily giving themselves enough rest time period or just doing too much of the same exercise over and over again,
Hmm.
or sport related. They're just not ready for the demands of the sport, say throwing. um, or you could have you know the, the programming doesn't seem that unreasonable, and when they perform the task, it's very clear that they're always biased in a certain way, and they can't shift out of that tendency or shift out of that biased position all the time. Um, just to give you a different example from a completely different body part, because I think it'll make more sense. Think of like knee position. So if someone who's always kind of like duck toed and toed out, and their femur is still oriented in a little bit more internal rotation relative to the tibia, um, that's that individual's genetic tendency. It's not always a problem though, but sometimes it is a problem, and sometimes you do need. It's not a bad thing to teach variability to be able to get them to be able to shift out of that tendency. In certain instances, based upon their history and what they're telling you, you think variability is a bigger component to their pain than, say, like, again, general physical preparedness. Maybe they just need to build more capacity and they'd be fine. But if they
Hmm.
have pretty good capacity and their overall programming from an external standpoint is pretty solid. Then you're starting to think more and more biomechanic related, as far as not distributing forces equally through their joint structure. Does that
Okay. Yeah.
make
Yeah,
sense?
absolutely. Yeah,
So
no,
it's just
that
more like critical analyzing the things that could be causing the pain, instead of just saying one thing is always the culprit of it and trying to always
yeah.
improve that one thing. Yeah.
Yeah, that's why when I like, this was a big article that the guy who's going to be my CI at Rehab to Perform, he gave me a bunch of readings. This big PRI
Yep.
one was one of them. And you read something like this, and at least I'm like, oh my God, like I'm not doing that. Like, this isn't my thought process. Like, it's just different. And it's like,
Yeah.
oh, I need to do exactly. But every time you read a new article, it's like, oh, that's what I'm missing. That's what I'm missing. So it's helpful to kind of, then I have to remind myself, well, no, it's just part of the picture. But then when I talk to someone like you, or, it's like, it kind of reinforces, well, this is how it's really used. There's only so much you could describe in a paragraph, which
Right.
is the limitation of just reading an article without talking to someone. Hey, how are you actually using this? When are you assessing it? Why does it matter? What is it changing from an
Right.
intervention standpoint?
Mhm.
Yeah, so it makes more sense, like when you describe, okay, yeah, the article's not wrong, but this is really how it's used on a more deeper basis.
Yeah. Yeah. It's hard to do that. It's hard to just kind of keep looking at it from a standpoint. If something works, then it's like, I want to try this on everybody, kind of a thing. But it doesn't work on everybody for a reason.
Yeah,
So it's I kind of use this analogy too. Like Tom, you like Tom Brady? You're a Michigan person, so you should.
yeah,
I don't know. There's some
yeah.
Michigan people who don't like it. So, like, he doesn't learn how to throw a football every single offseason. He just
Right.
learns how to read defenses and apply an offense to a particular defense that is going to work for him. Like, that's what he focused most of his time on. Granted, I don't actually know that. I'm just kind of assuming.
Right.
But like, if I was in that scenario, that would be what I would be focusing most of my time on. There's no sense of learning how to throw a football. I already know how to throw a football. So why do I need to learn a new skill all the time? Granted, new skills are necessary sometimes, but many times it's just being able to apply the skill in a way that's fit for the individual.
Hmm.
You don't necessarily need a bunch of different skills, and that's where the whole, like, get more tools for your toolbox kind of saying came from. But if you don't know how to use those tools given a scenario, then the tool doesn't make the person. Just like the paintbrush doesn't make the artist makes the paintbrush work for them.
Hmm.
So you have to be, that's where the art comes into play of coaching, as opposed to like the
Yeah.
science of it. Yeah.
Right. Yeah. No, definitely. That's definitely puts it in more of a practical perspective, which is the point of all of this.